Welcome to Kno2fy, a podcast recorded at the intersection of today's problems and tomorrow's care. Hosted by Kno2's Therasa Bell and Whitney Cole, Kno2fy brings together the voices shaping healthcare, from industry leaders and policymakers to the voices that don't always get the mic. We'll get into what's working, what's broken, and the hard conversations healthcare loves to avoid. This is Kno2fy. Let's talk about it.
Welcome back to Kno2fy. In our last episode, Kevin Holub walked us through what it took to go live as a CMS-Aligned network. Today, we're going broader. We're going to talk about what the CMS health tech ecosystem is, what's changing, and what does it mean for health plans, for providers, for patients that are watching and wondering what their next move is. So I'm joined today by my co-host, Therasa Bell. Therasa, how are you?
Great. It's another great day.
And then we've also got Kevin Holub here again with us. Kevin, welcome back.
Thank you for having me. I'm excited to be back.
I know we talked about it last time, but let's just hear a little bit about you, who you are, what you're doing.
Yeah, my name's Kevin Holub. I'm the Chief Product Officer at Counterpart Health. We are a wholly owned subsidiary of our parent company, Clover Health. I gave the longer intro, encourage you to go and listen to our first episode around this, but the short version, Clover Health is a publicly traded healthcare company. We run 3 business units, a Medicare Advantage plan, a clinical practice, and a technology business. I work and am Chief Product Officer of that technology business. Our mission as an organization is to improve every life. And so we're situated to help increase the liquidity of data, help make it such that providers are empowered with the data they need, to help patients get the right data that they need. And ultimately, we focus on the early diagnosis and longitudinal care management of chronic conditions.
So let's orient listeners a little bit. Kevin, I'll come to you first, and Therasa, I think you're going to have thoughts too, so I'm coming to you next. But what is the CMS health tech ecosystem? What's the CMS-Aligned networks concept? And why is it different from Kno2fy or other interoperability frameworks that we've talked about in the past?
I think one of the things that I've appreciated about what CMS is pushing for here is it's not a regulatory first perspective, it's an innovation first perspective. They've taken their weight as an organization. They're the biggest payer in the country. They're the biggest healthcare organization. And they've pushed that forward to make progress. And they said, who wants to meet us? Who wants to join us in breaking down the barriers that have historically existed? And because of that weight, because of that impact, they've invited a collection of innovators that have said, hey, we want to do more. And they've brought all of the constituents together. Some of the challenges of some of the legacy networks in different organizations, they were all incubated and started out of important requirements and necessity and needs and regulations, but it never really brought everyone together. This time, CMS is really pushing to have payers, providers, patients, health tech networks, apps, EHRs, everyone that I can think of, they're all part of the network. They're being inclusive, and they're challenging all of us to move faster. And so that's really been, for me, something that's different than some of the legacy opportunities we've pushed on here. The history has been really focused on how do we do the regulatory framework? How do we set this up in a trust-based network? And it's really hard work. CMS started with the assumption that that's there and said, how do we move faster and do more? And that's what the CMS health tech ecosystem is to me. That's my understanding, and where I'm pushing on it is trying to be on that innovative side so that we can set the pattern of what's possible that over time will become the regulations and the rules. But we're going to lead at not the floor, but we're going to look for the ceiling of opportunity as a community.
I'd say I'd agree with Kevin. So if you do a kind of a historical review of interoperability initiatives in the industry, it's always been around the framework and the protocols, right? Super boring stuff. Like never, sorry, no offense to those of my own kind, because I've been right there with them. But that's what the history of interoperability has been. And necessary, right? So we've pushed through the interoperability frameworks, the governance, the trust, and it's gotten us really far. but not far enough. It hasn't, obviously, we're sitting here today still talking about it. So something's been missing. And I would say that's where CMS, so TEFCA continued on that course, right? Where it's the national, this time endorsed by the federal government, huge differentiator from previous examples that I've given. But still around regulatory framework, trust, all the things that are important, but you're going to move about that as fast as I'm speaking right now. You're going to move about that fast. On the flip side, CMS was about use case and outcome. And so they're saying, hey, and I'm putting words in their mouth. They haven't said this, that you can just read between the lines, saying, you know what? We've got a 60 million plus Medicare Advantage, Medicare patients that are sitting in this, in this country, and we're running out of money. We're going to be insolvent by a certain period of time, and 25% of waste in healthcare, 25 cents of every dollar is waste, which a huge percentage of that is related to data moving at scale, right? And our ability to innovate on data moving at scale. So CMS is saying, you know what, I'm getting to the outcome. This is the use cases that we've identified, and we're going to hit the gas pedal. How you guys get there, you figure it out. You figure it out. But we all collectively need to get that piece done, because we're all going to be in a pickle if we don't get that, if we don't get that done, right? So we've really got two very complementary groups here that for Kno2fy, it's been an interesting dynamic. I can speak to it personally. It's been an interesting dynamic to know how to bring those together. And I'm really proud of how we've done that here with groups like Counter and Clover and our other partners, where we've taken the regulatory, the protocol, the ones and the zeros, I say, of TEFCA, with the initiative and the drive of CMS, and get to the outcome. And sometimes we've had to use our private network because we can't wait for some of it to be done. So we'll use our private network and our ability to influence our audience to meet the objective, just like CMS wanted. But those are kind of the key differences here. And it's really up to the network. I'd say it's the responsibility of the network, being ourselves here, that we have to bring those two together for the partners that are sitting with us and saying, okay, guide us. We're interested. We want to get it done. We're there, but tell us what to do and what to do next. And that's our role in it.
I'd like to hear a little bit more, if you can, about how, as a federally designated QHIN and a CMS-Aligned network, you kind of touched on it, but tell me more about how it works together and why does that matter for partners that may be evaluating their options?
Can I throw the private network in there too, Whitney?
Absolutely. Please do.
The three come together, really. So how does it work together? Well, it's really picking, first of all, we pick the use case and we apply the protocol to it. So in this case, Kevin came forward and said, we're going to make claims data available to patients and providers. And then we say, how? And the how is through, at scale, right, is individual access services. Okay, we're going to go back to the TEFCA framework, which we've built into the Kno2fy network, and do that. And then we move to, do we have the private network that are capable of both communicating back and forth on that? And we were able to move the private network to say, make sure you are supporting this, because this payer is now live and you've not had that. Conversely, talk about the example of payer, so payment. So now Clover wants to get access to providers. Well, we can't use the TEFCA framework right now, because payment is an optional use case through the TEFCA framework. So we're going to use our private network to allow for the same API call for Clover with a payment purpose of use code on it to now hit our private network and say, and we can move that private network to say, allow this to come through for this group called Clover. As you look at allowing and securing the pipes, because they've got the same concerns as everybody else from a security and privacy perspective, but allow it to come through. So that dynamic, and that's why I say it's really on the shoulders of the CMS-Aligned network and the QHIN to make sure we're guiding it correctly. But use case first. Let's not start with the protocol first. Let's go use case first and start to drive some real outcomes to what we want to see being done. And that played out in the last few weeks. Absolutely has played out and has proven to be true.
So walk us through then what is changing for a health plan when they're live on a CMS-Aligned network? Kevin, I think you might have a really good perspective on this. What can a health plan do Monday morning that they couldn't do the Friday before they were live?
One of the things that I think is really important is we can more appropriately share the data we have with the right participants to get their data. That means patients can more easily get access to their own data, and providers can more effectively get access to a wider longitudinal patient record through the claims data set. First and foremost, to me as a health plan, that empowers the right people with the data they need to hopefully improve long-term care, which will over time bring down cost for me as a payer. Right? That's my goal, is to help get people the best care possible so that I can decrease the medical expense that we incur. That's the first thing, is we're helping with that data liquidity. And so now, without needing to log into a separate portal, you as a patient can get your own data. Now, as a provider who's looking for the full treatment data set for your patient, you can now get your full treatment data set, including the claims data. So that's one thing that's very real that a payer can do, is they can more effectively share their data through, as Theresa said, guardrail protocols. They're set up. There's ways to do it now. We've broken through that barrier. It's done. There's a clear way to do it. A big innovation was able to happen through the private network that we promoted to the public network now. CMS-Aligned networks are continuing to push down that path. The other piece is what Theresa said as well, is there are other use cases for us as a payer that through the CMS health tech ecosystem, CMS has promoted as saying, here's 2 specific use cases for payers that they want to promote. One is for every claim that comes in within 60 days, a payer can request the clinical records for that claim to make sure that it's paid appropriately. And then the second use case that they've talked about is clinical quality. Health plans and Medicare Advantage plans are required under CMS frameworks to do a lot of work around quality. It's a good thing. It's called the STARS program. Within that specifically, there's one of the subcomponents and more programs called HEDIS. There's a lot of longitudinal clinical data around preventative medicine that we want to encourage our members to get. A lot of that's locked up before they became one of my members, right? You can get a colonoscopy anytime in the last 10 years. So if you join Clover and you age into Medicare and you choose us as your health plan, and you got a colonoscopy 4 years ago, without something like the CMS health tech ecosystem and the CMS-Aligned networks, those doctors would have to call up other people. We'd have to go look for those records. We might ask that member to do another colonoscopy. That's bad. A better way is to leverage the networks that exist and say, does this patient need a colonoscopy? No, they got a colonoscopy 4 years ago. Let's get that result to the primary care physician and let that physician do the right clinical follow-up versus us running down this administrative process. As Theresa said, there's a lot of waste that goes into those programs. That data liquidity will decrease that waste. And so those are things now that payers can actually get access to. There's reciprocity. Provide the claims data. Through providing that claims data, you now have access to the payment purpose of use for 60-day claims, as well as the clinical data for care quality. Those two become new functionality that have not historically been supported on legacy QHIN and Kno2fy networks, and some of the legacy networks that have existed. Those just didn't exist.
So it sounds like when you do right by people, the rest follows. It benefits patients, it benefits providers, and it benefits the payer. Is that what I'm hearing?
Absolutely. Our goal and our mission is to improve every life. As a Medicare Advantage plan, the best way we can be successful is actually to get patients better care. And so by sharing data, by participating in these networks, by allowing these different workflows to happen, we can hopefully support patients getting better care. And over time, for us as an insurance company, doing better because patients are healthier.
I would say, Whitney, and I'm curious on your opinion here, Kevin. I've always wondered how much truth there's been to all of the big bad pictures that have been painted about providers, EHRs, payers, whoever it is. And at the end of the day, by Clover, Counterpart taking the first move and saying, we're going to make our data available, we'd love it if you did. I am curious on that kind of camaraderie and that kind of sharing. Is a lot of that stuff true, or has it just been a factor of the market the discussions, like it just feels like there's been a lot of swirl that underneath it all. I venture to say that the most, not all, but most are wanting to share data and share data at scale because of, and most meaning providers, payers, and EHR vendors, technologies, all of them. They're wanting to share data. There's a few holdouts for sure. But by making the first move, right, and showing it, if we had a few of people with the spirit of Clover and Counterpart, I think we just start to see the dominoes fall, and it just starts to push forward. And I think that's the hope, by the way, of CMS-aligned networks too. You have a few first, and it becomes like a FOMO, right? Like if I don't, somebody else is gonna. And I kind of bought into that. I think that could actually work here, based on what we're seeing. But I am always curious on how much of that's real.
I think there's going to be pockets of people that are concerned, but I think it's more fear, uncertainty, and doubt than it is true risk when data starts sharing. There are places. Some payer is going to act poorly and use the data to deny claims. Some provider group is going to use the data to negotiate a better reimbursement rate. There's going to be places that happens. But if we focus on the risk of data illiquidity, we're going to miss the opportunity that 95% of use cases are going to get better. So I do think we need to flip and say, hey, let's define the risks. Let's be better about protecting for them. But if we actually start focusing on the thing that matters, which is better patient care for members and better patient care for patients, we're all aligned with that, actually. Let's set up the system to do that instead of focusing on these edge case risks. We need to have organizations. There's always going to be abuse, but we can't let the long tail risks get in the way of progress. And I'm excited that we're pushing to do that. And I agree with you, Therasa. I think as the first couple of organizations go here, we'll see that there's less proprietary data in the Karen Blue Button implementation of claims, which doesn't include financial metrics, being shared to providers. There's not as much risk there as the payer. And for providers, hopefully they'll see sharing the data through a more efficient mechanism is better than our current legacy system of faxes and calls and demand letters and legal. We could cut that out and just share data better.
Yeah, I think the prioritization of risk we have wrong in this country, because the biggest risk we have is insolvency, and we don't talk about that. And it is a real 2032 risk that we have of insolvency, and that should be the risk that is making every one of our decisions right now. It's like choosing not to be on the internet because I'm afraid of a cyber threat. Well, the cyber threats are extremely real, more real now today than they've ever been. And I don't know of a single business that's going to shut down their internet, right? That's going to say, hey, it's just too much for us. We're going to go ahead and close that off. And that is the exact same analogy that we have here. And our risk prioritization is off. And it has been for a long time. We lose sight of what the realities are.
So as an early adopter, Kevin, I think you probably learned some things. You were charting your own course. Can you talk to us about lessons learned, things you experienced that maybe you didn't expect?
I think one of my short-term lessons learned right now is the level of complexity of a distributed network. Part of the challenge of something like a QHIN and Untitled and part of the challenge of the CMS-aligned networks is both good. There's a lot of innovation that's happening. There's competition amongst the networks, but the coordination then between the networks is hard. So we're grateful for partners like Kno2fy. One of the things that we've seen in the last couple of months and quarters is little things get in the way. Two different networks have different ways of structuring country codes. Two different networks have different capitalization in different places for enums. Different networks have different latency requirements. All of those things are real. And until you start actually doing it, you're not going to run into those problems. The testing environments and the staging environments, they're all good to learn, but until you're in production, you won't really run into it. So part of it is being very thoughtful that moving early, pushing the bounds, you have to be ready to support that and have partners that can support that with you to go and do those things that ultimately need to get done. So that's one learning. The other is as we were just talking about, the boogeyman isn't real. Once you start sharing data, what happens is more data sharing encourages more data sharing, which is encouraging better patient outcomes, is encouraging more informed patients, is getting better outcomes. So are there risks? For sure. But the other part is, I think those risks are overblown. We've done really good work as an industry, making a lot of progress on the foundations. There are really important protocols in place. IAL2 makes it easy to trust someone, right? It's so much harder to fake an IAL2 authentication in a biometric face scan. We can trust that. I don't have to worry as much about those pieces. Those things all help grease the flywheel and allow us to move faster in progress.
I think Kevin said a couple things that are, one, it gives me a huge amount of anxiety at the same time that I need to continue to improve. But thank you for the shout out, Kevin, because it's never good enough. Just ask the team. The internal work and the responsibility we bear as a CMS-aligned network and as a QHIN, as a private network, and I'm just going to say as a network, is exactly what Kevin described. I've had a number of interesting groups come to me and say, well, we think we could be a QHIN. I'm like, good luck. Good luck. It's not just meet the technical framework and check the box, right? The orchestration across the different communities. Now we add in, we're care quality, we're CMS aligned, we have our own private network, and we're continuing to push into our private network to supersede the other networks. Sorry, that's hopefully not a dismay to anybody. But the amount of calm that we have to bring to that, so we normalize that experience, and it's really, really tough. Until you're in real life production scenarios, you can't encounter every issue. And we've had the privilege, and that's why Clover and Counterpart are so unique, because they don't get flustered by that stuff. It's like, okay, wait, we just got to fix this, next thing, and the intestinal fortitude to push through to the end. We need those types of partners, and then we'll take care of normalizing that across all of these different ecosystems. It's hard work. An interesting point, because we're both product manufacturers, right? Counterpart is, Kno2fy is, at the highest level. And I'm sure, Kevin, you guys have a PDLC or a version of a PDLC internally, right? That you use for product releases. We have actually, and we're going through a metamorphosis of not using a traditional PDLC within Kno2fy, and we're transforming it and moving it to what I call the NDLC. So the network development lifecycle. And the reason the NDLC has become super important to our team, and we're just going through this actively, is for the reasons you just stated, but because we always have more than one party involved, and one of those parties, at least one of those parties, is not under our control. And so when we release something, we don't have a captive user audience, right? I've got a user audience, and then I've got the bigger audience that are both subject to the value of my network and what I've done on the product. And a little bit of a tangent here, but to demonstrate the challenges and the need for partners like a Clover and a Counterpart to push through, so we can continue to be in production. And because until we're in production, unfortunately, we can't uncover some of these things. But we're willing to do it, and it's a hard but aggressive pattern that we continue to push forward on with meeting these initiatives. And we'll get there. We'll continue to push in.
So eyes are on you, Kevin, and Counterpart Clover Health team as a early adopter. What would you tell the leadership at a regional health plan who's watching and wondering, like, we want to do this, how do we do it? What advice would you give them?
One, I think you can come and talk to Counterpart and Kno2fy, and we can help get you online faster than I think you think. And the second part really is that, again, going back to that point, the FUD is real, the boogeyman is, they're not. Sharing this data, participating in these networks, there's more value to be created by joining than from hiding. So for us, come on Counterpart. We'll help you go live on the networks. We'll work with Kno2fy. We'll get your data flowing. We can help your providers get access to this through our solutions. This is all ready to go. The technologies exist. It's about a will and an interest to try to move forward and help patients get better outcomes. It's a desire to move out of the waiting game of legacy health plan and into the future where everyone is going to really push faster and see that those changes actually are part of the solution to the problem. Therasa brought up insolvency in the Medicare Advantage market. There's a lot of competition. There's a lot of plans that are retreating and struggling to be profitable. The best way to be profitable is to get members better care so they cost less. There are solutions out there, but they require you to take some risk, jump out there and actually provide data liquidity, give data to the right providers, give them the tooling that's needed. And there are partners ready to run. Organizations can move quickly to solve those problems. They feel hard, but we can do it.
What does the roadmap look like? If you were going to lay it out for one of your peers, what would you say? Here's your next 30, 60, 90-day plan.
I think we've shown through our partnership with Kno2fy that it takes less than 30 days. So I'd say, I don't need a 90-day plan. Let's go live. And so would go and talk to them about sharing their data, right? They've got their claims data in a claims engine somewhere. They've got it in some data warehouse. They've got CMS requirements and CMS-0057, which is another set of rules coming down the road about sharing data. You've got a lot of things moving. Don't forget that you could go faster than the regulatory floor. And we could do that quickly. We can come online with you quickly. We could partner with someone like Kno2fy who's ready to run, who can scale at the level we're talking about. These networks exist. We can connect. We can turn this all on. And we can do it, I think, faster than most people expect. I think part of what I've really enjoyed about the partnership with Kno2fy is we can move fast. A lot of organizations are, okay, it's a 6-month implementation playbook. And I think that's wrong. It's here today. We can do it. Let's move. These things exist. It's part of what's made Kno2fy's communication framework versus this complicated network strategy really clear. I'm going to do one thing. I need to go find records. I'm going to share records. I'm going to do something. That's where Kno2fy exists. They deal with the network. So you, as a health plan, you just got to get going, get started.
Yeah, I always say you got to want it. Like if you have a 6-month playbook, that same playbook could be 9 months. That same playbook could be 3 months, and people will fill the time that it says. And that is like a known human behavior. And so you got to want it. And you put out there, this is what we're achieving. You pick the time that you want to do it in, whether it's 5 days, 1 month, whatever that may look like for your organization, but you got to want it. You got to have, I'll use that word again, the intestinal fortitude to push through. If you want it, it'll happen. And it's there to be had.
I'll add to that as well, that intestinal fortitude, the world around us is changing faster than what a 6-month or 3-year timeline can even look like. I don't think last summer when many of us were invited to the first kickoff of the CMS health tech ecosystem, we all kind of like, what is this thing? 9 months later, payer data exchange is happening on networks. It's real. So I don't want to wait for what my 3-year timeline is going to get blown up. AI is moving faster than I think any of us can plan for. I think we need to start getting off the planning stages and start getting to the doing stages.
I think it's really funny you say that, Kevin, because I was talking to our team internally about when I had the privilege of going back to the White House, and they asked us to take a pledge, and I'm like, close my eyes, just sign. Here we go. Because we really don't know, but I knew enough to say, we're all in on this interop thing. So whatever it's going to be, and here we go. But it was like, you had no idea. You just closed your eyes and signed. And you go.
CMS says jump, we say how high.
That's right. That's right.
All right. Well, I think that's a good place to leave this one. Thank you, Kevin, again, for being here today.
Thank you so much for having me. It's great to be on the podcast and to be a customer.
And thanks, Therasa.
Thank you. I haven't gotten kicked off yet.
Waiting.
And that's a wrap on Kno2fy. To learn more about Kno2fy, or if this episode sparked something, visit Kno2fy.com. We'll see you next time.